the September board of the Worcestershire Acute NHS Trust. We've had a busy morning already today, talking about a variety of different issues. A wonderful patient story from our trauma and orthopaedic team started off our day. We then did some work on EDI mentoring and reverse mentoring, which is a program we've got going, which I think will be very important going forwards. And then a series of other discussions about the way we're trying to reorganise our services to drive performance during the second half and into next year. As you'll see from when we get into the numbers, we've had a reasonable first half, but the challenges for the second half are very real, with the combination of winter coming, the potential for further strike action, but more importantly, our own need, which is within our own control, albeit not easy, to ensure that we drive productivity and cost efficiency throughout all of our services and ensure we deliver for the people of Worcestershire. But there is some really good work going on, which we will get to, no doubt, when we get into the individual reports from members of the team. So we have apologies from Alex Moran and Karen Martin. I don't think we've got any other apologies. Joe, a couple of colleagues may be running late. Rena, lovely to see you at the board. Any declarations of interest, colleagues, which we need to announce? Hayley, I know this is your first board with us, and really great welcome to you. Lovely to have you on board. No declarations of interest from you? Okay, super. And the minutes of the meeting held on the 8th of July, were there any points of accuracy from colleagues which you would like us to adjust? If you could put up a digital hand, please, that would be great. Okay, I can't see any digital hands raised. So in terms of action points arising, we go to page 6, and then there was only one regarding an update regarding the recent stroke rehabilitation changes. Jules, do you just want to talk to us a bit where we are with that?
Yes, thank you, Chair. So the new process was put into place, started in July. So we've got some of our stroke consultants rotating out into our community centres, delivering care there for patients on our stroke pathways. That initially has gone very well, some good initial feedback, good engagement from colleagues across the patch really with regards to that, and showing some initial positive benefits with a reduced length of stay in those rehabilitation wards over July, but obviously we'll be on continuing the monitoring in that, and the benefits realisation will follow in due course.
Thanks, Jules. Jules, sorry to ask this question with that forewarning, but in terms of incidence of stroke in Worcestershire, I would assume we're seeing an increase in incidence of strokes just with our ageing population. Is that a correct assumption?
I would be with you on that assumption, Chair, but to be honest, I don't know the figure off the top of my head, so I will find out and feed back to you.
That's wonderful. Thank you, Jules. Any questions on Jules' update on the stroke rehabilitation services? Just for the assurance of members of the public, you know, we are very conscious as a board and with our colleagues in Herefordshire as well about the importance of early intervention if you have a stroke. And I would just remind members of the public that if you see a change in a friend or loved one's face, arms, speech, then immediately telephone emergency services. So FAST, F-A-S-T. Early interventions in stroke can help avoid life changes for the individual. Any matters arising the colleagues feel we've missed, please raise a digital hand. So we'll move on then to the Foundation Group Public Board minutes from the meeting held on the 6th of August. Any points of accuracy, colleagues, from Worcestershire on those minutes? Okay, they'll go to the next meeting, and then the actions and matters arising from that meeting will be taken forward to that next full board meeting. I would encourage members of the public who might be listening to this live stream later to come along to one of those 4 board meetings. They are quite different in terms of arrangement, but they really do allow us to do comparisons across the foundation group in terms of area of performance and to drive the purpose of the foundation group, which is to identify and share best practice at pace. And there are lots of opportunities that come out of those discussions. So without further ado then, we'll move on to the Chief Executive's report. And Stephen, an awful lot happening, but how are you seeing things?
Yes, thanks, Chair. There is an awful lot happening and an awful lot about to happen as well, and some of it's relevant today with the publication of the Performance League tables, which I'll touch on. The first thing that I wanted to draw out is we are now going to be entering a phase where we're looking at a multi-year time frame for planning, which I think it will be challenging for all trusts and the NHS to work it through in terms of the timeline that we want to achieve that by and the detail that we want to get into. But I have said in the report, I think overall that's to be really welcomed, because I think for a long time a number of us would have been frustrated by the yearly planning cycle, which kind of stopped us having more of that long-term view. Also linking it then to the particularly the financial allocations, strategic commissioning of where services were going, what they were going to look like, and also importantly the capital allocation, which has always been an issue for the trust. So there's an awful lot of work that we've got to do and take board through in the time frame, but I think we can't lose sight of that this is a welcome change to what we've traditionally done. I've set out in there how hopefully that mechanics and engineering work of all that in terms of the 10-year health plan, the neighbourhood health plan, how that fits together and who's responsible for what. So I think we're definitely moving to a time where it's becoming a bit clearer now about what us as a provider would be responsible, what the ICB would be responsible for, region and the national team. So hopefully that is looking promising, and we'll keep board and people updated on that one. The other, as I mentioned, is the publication of the National Oversight Framework, which was released today to the public, but we have been having a look at, and that drives our segments and how we're performing as a trust. So we're segment 4 at the minute. When we've taken board through, when you unpick those scores, actually a lot of the performance and the quality indicators are not too far off. We will be around segment 2. The disproportionate thing that is keeping us towards segment 4 is around not just the deficit, but the productivity challenge that we've got in the trust. And that links to a number of things that will be played out through board, such as banking agency usage that we have as a trust, some of the operational metrics that we've got, particularly UEC. But we will obviously keep board updated on that and members of the public, and we have received some media interest around it. I think this will develop and evolve. And the other important thing is that this is a new framework, and it's based on a relative performance. So you can move up and down depending on how other trusts are performing. So even if your metric is moving in a positive direction, if others have gone further and faster, you may appear lower. So we're just working through that, and I think there's some important bits that we're working through with Richard and our key stakeholders to make sure that's explained. Where we've got issues, we always have been and we always will be honest and open about those and be really clear about what we've got to do. But some of the mechanics of the framework just need a bit of explaining. Attached to that, then, we've been given a board capability framework every trust has to fill in, and that will, alongside with your segment score, help form a judgment on where you are as a trust, any additional support that you may need. And I think it will be used at some point to determine those trusts that were in that really intensive support. So we'll complete that, we'll take board through that, and again, as we go through, we'll bring that through public board as well, in whatever form we can. But board members will see that as we start to collate the responses and the evidence. I've detailed the sections that are going to be measured against that. The other bits I just wanted to pull out are, and again, I think we really welcome this. There's been a lot of discussion around resident doctors. predominantly in the media, it's been driven by the pay and the industrial action that's been there, but actually underpinning some of that is the working conditions and how some of their working life is structured. And I think really importantly, we've now received, there's a 10-point plan. I would say our foundation group chief executive must have been in there somewhere because he did like a 10-point plan. But there's a list of things there that are there to drive an improvement in the resident doctor's experience. Jules is leading on that as Chief Medical Officer. There are regular returns and other things that we have to take through. So again, I wanted to signal that to the board, and we will take that through our governance routes, and we'll work out how we build that into things like our finance and performance executives and things like that to make sure that we're really keeping a grip on that. Then finally, we've got more from our teams, and for all that the NHS can be a difficult place and there's a lot of difficult media around it, we can't be discouraged. We've got some staff doing some absolutely brilliant things out there. And one of the things that I think we should be rightly proud of is the surgical hub accreditation, both at the Alexandra and at Kidderminster. We've mentioned the Alexandra one here, but Kidderminster came shortly after. And actually for the trust, that's 3 accreditations. We've got 2, one at Kidderminster, one at Redditch for adults, but we've actually got a paediatric one as well at Kidderminster. So that gives us real potential to go forward, and the trick now is to maximise that. But what was really pleasing in the feedback was the feedback on the teams and how they worked together. They were really patient-centric, really heartwarming feedback on that. So I really want to extend my thanks there. And then there's the cardiology pharmaceutical grant, which is brilliant because I think we want to be, we really do want to play a role in research. And Dr. David Wilson has received that. As an aside, I would say writing this report and seeing that has particularly reminded me why I trained as a mental health nurse, so that I didn't have to use massive complicated words that are in there for conditions that I have absolutely no idea what they're about. But I just want to say congratulations to Dr. Wilson. And then lastly, the garden transformation. So another really vibrant part of the trust is our volunteers. And although not in the report, I will be bringing back the P&E volunteers that have recently started on our end of life pathway, which is brilliant. But we have volunteers here who've all worked at the Alexandra around transforming the garden spaces for our patients, visitors and staff. And a particular shout to the Redditch 41 Club who held that. And again, the link with the community is really important to us. Happy to take any questions.
Thanks, Stephen. Any questions or perspectives to Stephen? Simon?
I know it's early days yet, Stephen, but do you have any idea what neighbourhood health, the neighbourhood health agenda is going to look like? What differences it might make to us? I know it's early days, but do you have a mind's eye picture of what you think it will look like and where we'll be playing a role in that?
Yeah, so there have been some, there will be announced some neighbourhood pilots, which I think will look slightly, each pilot will look slightly different. So I think they will, what we'll see evolving over the next few months and into the year is, I think we'll start to coalesce on what the outcome is we want, but each locality gets to decide how it does it for its population. These pilots will test that. In terms of us for Worcestershire, we've had some really good conversations with primary care and the Health and Care Trust about how we all come together to create that neighbourhood health. My guess would be in Worcestershire, it may look slightly different in each of the areas. And one of the things we're going to have to work through is what's the population footprint we're working on. Because with all these things, you can't be too small that it's ineffective, you can't be too big, so it becomes lost in the whole Worcestershire bit. There will be some clear areas that we've got to work on. Frailty will be one, because that's a big one, that's through all of us. So I think it's an evolving picture. I think we've got a rough mind's eye of what it might look like, but it's just how we work that together. And I think for colleagues who may be watching it, I started off, we came together to do an evaluation of the primary care accelerator sites recently, and this had just landed neighbourhood health. And one of the bits I said was, if the first question we're asking is about leadership and governance, we're asking the wrong question. It should be, what are we trying to do for that? What is it this population need, and how do we just organise ourselves for that? So Don't know if that helps, Simon, but it's just evolving through that.
Thank you, Stephen. I think that the more general theme, Simon, is I'm encouraging both Stephen at Worcestershire and Wye Valley to help develop schemes where, although we might not be an IHO, because of our financial situation, we can behave like an IHO with partners. So there is work going on behind the scenes, which will come to the fore. Can't see any other hands up. Just a couple of quick ones for me, Stephen. Just first of all, for our staff colleagues, I'm conscious with from feedback from the Facebook pages that we have for our staff, with the return from school, the car park is getting clogged up again. Just to confirm, the Worcestershire County Council car park site is available to staff. We strongly encourage them to use it. It's much easier to get in and out. And we know it will become more difficult as winter approaches, but that car park is available. And Stephen, just when it does start to get dark, have we got plans in place so that, particularly for colleagues who might feel vulnerable walking across the path in the dark, that we try and improve the lighting or provide torches? Can you just brief us on where we are with that?
Yes, and this will play. We have had a question come in as well around the County Hall car park, so I can address that as well now with it. So there were two parts of the question, if I cover that. One is I would definitely encourage people to start using County Hall. It has a separate access and egress, so you are not snarled up in the problems that we've got here, or we have experienced. That's why we were keen on it as an option. If we do that, one of the questions has been around patient car parking and if we can improve that. So one of the options we've got is if more staff move to the County Hall option, the main car park has a flexible barrier, so we can actually increase the patient car park. We can do both, and we will look to do that. In terms of your bit, that was part of the question as well. So we are as the nights draw in, we've agreed security that will walk between the sites, and we've agreed with the council, although it's council land, we will be putting lighting up as well. So there'll be lighting and increased security, particularly for those periods at dark. We are encouraging particularly 9 to 5 staff or staff that are in more daylight hours and their work is more predictable like that. They use that, and then those shift workers that are particularly late at night then have access to the main car parks, which are obviously covered by us anyway. So you will see, as the nights close, an increased security, increased lighting.
That's super. Thank you, Stephen. My second question was really on behalf of families who lose loved ones on our side. There has been the press comments made about our excess capacity facility on the mortuary, which I know a lot of work's going on in terms of ensuring that we always provide a dignified service for those who have lost loved ones. Do you just want to touch on that, as you didn't mention it in your overview?
Yeah, so the report that was alluded to in the media was that the Human Tissue Authority is the one who do the inspections. As most trusted, in planning for the pandemic, when that was on, they created excess mortuary space to give some assurance. It is adjacent to, it is next to the mortuary. It's a purpose-built unit, and the area that they refer to is a very private, barrier-controlled area to get into. They refer to it as a car park. It's actually used by transportation from the main hospital into the mortuary, but also for local funeral directors who are taking deceased away. The issue was that because it is temporary, we need to do a bit of work to make sure that the canopy fully covers, and there is absolutely no chance of anybody seeing it as a car pulls up, anybody seeing anything. That's what we're doing, that's what we're working on. We are doing some main work in the mortuary as well, so that's the issue that we've got to resolve there.
No, thank you, Stephen. I just wanted to assure members of the public that dignity was always at the forefront of our minds on all of our mortuary services. So without further ado, and apologies, we're now running 5 minutes late. We'll move on to the integrated performance report. Your introduction, Stephen, then we'll go to each of the team.
Yeah, I'll be relatively brief. So you can see the pressure that's maintained in our urgent and emergency care pathways, although because of some of the work that we've been doing, particularly around ambulance handover times, we have been moved out of the tier 1 system into tier 2 as we reflect our plan. I'll let others go through most of the other operational performance issues. Elective is generally where we want it to be. Cancer is still going a little bit up and down, and our relationship with tertiary partners is one that we're working really closely on. In terms of quality, there's an absolute focus on fracture neck of femur, and we heard from the board this morning, as you said, about the patient story. We have done some work with that team as well about their bed base, so we've made some internal move around in the hospital, so hopefully that will help. And then finally, I think just to bring on what you said in terms of the money, we are slightly ahead of plan. However, the next months into the end of the financial year will be extremely challenging, not only because of likely operational pressures we'll face, but our efficiency programme was loaded in such a way. So the disproportionate focus, I think, on maintaining that operational grip, maintaining that flow, but on our agency spend in particular, becomes more disproportionate, I think, through the year. So there's a lot of executive focus on that.
Okay, super. Thank you, Stephen. Key thing is for us not to make excuses when we're not performing, just to find solutions as best we're able. Any questions to Stephen? Otherwise, we'll dive into the detail. There's a slight mismatch between the agenda and the board pack in terms of running order, so I'll follow the board pack. So we'll do quality and safety first. And Jules and Hayley, over to you.
Thank you, Chair. I thought I'd probably, as it's Hayley's first board, I shall lead. I want to throw her straight in at the deep end. Work is continuing, some good work continuing in our antimicrobial stewardship agenda, with some good compliance being shown there. Obviously still a little bit of improvement to be made, but some good compliance in that field. There's also some really strong work going on in the improvement of our management of the deteriorating patient work streams, and we're making good progress with the implementation of Martha's Rule. Our summary hospital level mortality indicators remain as expected, so no areas of concern flagging, although we are monitoring that closely and to look for any changes or any trends that we feel we need to respond to. That's being managed through our Learning from Deaths forums. We are also, as Stephen has alluded to, focusing very much on improving our fracture neck of femur performance for our patients who are being managed through that pathway. Although the data for July, which is the pack we're looking at, still remains challenged, I'm pleased to say that we should, for next board, be seeing the improvements, or at least a step in the right direction for the improvements that we have been hoping for. So I'm optimistic that work will continue. Some really positive things happening in that space as well, Chair.
Thank you, Jules. Hayley, is there anything you'd like to add? Conscious of the fact it's only a few days in.
No, it's fine. So there's lots of work going on in the infection prevention and control space. So working very closely with our NHSE colleagues regionally, and we've got a planned visit in September. So we're working towards that. And also, I'm just trying to get my head around all of our assurances and how, as the chief nurse, I have total assurances regarding our quality portfolio. But yes, it's only day 7, so please bear with me. Thank you.
No, we will do, Hayley. And one of the wonderful things about joining the foundation group is, even though Sarah Shingler has left the building, she hasn't left the group.
Absolutely.
So she's always just down the line, so to speak. Any questions or perspectives to Jules or Hayley? Jules, what's worrying you most?
I think still the focus on the basics, Chair. We still need to make sure we've got our fundamentals correct. I think having a new chief nurse in the space is actually a real opportunity for us. So myself and Hayley will be working really closely together over the next weeks and months, just to take the opportunity to review where we are. It's very interesting when somebody new comes in and asks you questions. It helps you to clarify what you know and what you don't know within the organisation. So that's been a really useful exercise to take. So I think, yeah, the basics to answer the question, Chair, that's where we need to be focusing.
Can you just hold? Okay, team. If there are no other questions, we'll move on to Chris. Chris, over to you.
Thanks very much, Chair. So I'll just take us through the three main sections of the operational performance agenda. So starting with urgent and emergency care. So we do continue to see improvements in ambulance handover delays and improvements in the number of patients spending over 12 hours in our department. And we are also seeing sustained triage performance in both departments. I do want to make a quick shout out to the Alex for the team there in terms of who are frequently the top in the region in terms of ambulance handover times, averaging generally less than 50 minutes of their handovers, and on most days achieving 100% within 45 minutes. But EAS isn't improving at the pace we would like it to. It is making some improvements, not at the pace we require and that our patients deserve. There are a number of contributing factors to this. One significant is the continued increase in attendances. There are frequently hours now where we're seeing sustained attendances over the 85th percentile of the numbers we would expect, which is adding additional pressure on to the team. And we continue to experience flow challenges across and out with the organisation. In terms of some of the things we're doing about it, the ED team are reviewing their rota, not to increase staff, but to make sure the staffing rota is matched to where demand is coming into the organisation, so that people can be seen by a doctor within 60 minutes. We moved the GP in ED from the current ED department into the old ED department on the Worcestershire Royal site, which will release space in the department. And we've got an ED navigator pilot who will help to stream patients who arrive at the emergency department whose care can be better met elsewhere into the right location. We're working with partners in the community in terms of maintaining the flow out of our organisation, particularly those who require a complex pathway. And the big thing that we're looking now is that we've secured funding for a hospital at home or virtual wards. So it's from the ICB or the Integrated Care Board that will create 30 virtual ward beds and 15 virtual ward beds for respiratory, building on the COPD virtual ward we already have. That will start to launch in October. We'll see the full benefits of that playing out into the later stages of winter in January once full recruitment's taken place. We continue to work with ESIS, who are the emergency care intensive support team, around the frailty model in terms of our frailty model internally, but again with community partners. And one of the benefits of being stepped out of Tier 1 to Tier 2 is the amount of ESIS support we're able to access. But I would like to just say a big thank you to the support we've had from ESIS while we've been in Tier 1, because it's really made a significant difference to how we've been able to work with teams in terms of bringing a critical friend approach and working with us to make changes we need to make. Risks in terms of the improvements, I think there's still potential risk around further industrial action. I think the failure of the demand management schemes in the community is a potential risk in terms of what it looks like for us going forward. And again, any risks around the challenges around the complex discharge processes and capacity to keep up with the demand that leave more patients in our hospital whose care can be better met elsewhere. If I move on to elective and to cancer, so as Stephen's alluded to, the elective positions broadly on target for where we expect it to be. For those where it's slightly off, I'd expect that to recover in September or October at the latest in a couple of specialties. We're particularly challenged around ENT, oral surgery, trauma orthopaedics and gastroenterology in terms of the reductions we require for 52 weeks, being less than 1% by the end of the year. However, all of those areas have got recovery plans in place that have been developed jointly between operational and clinical teams to get back on track in line with the timescales I've set out above. We are focusing on both ends of the pathway for patients who have an elective need, so that we can see patients more quickly at the beginning, so that those that don't need anything can be reassured of their condition and no longer require any hospital intervention in terms of really focusing on the outpatients, so we can reduce our overall waiting list. And the productivity focus we oversee through the Operational Assurance Committee to make sure that we maximise the number of patients that we do treat in line with our activity plan for this year. If I then move on to cancer, so cancer probably is my biggest area of concern in terms of the operational delivery. So whilst UEC is challenged, we are making some progress, and I think we're fully sighted on the work we need to do there. However, cancer has deteriorated in recent months in a number of areas and that's led us to be in tier 2 for cancer in this quarter. Personally, I'm quite disappointed given where we were at the end of last financial year about the deteriorations in the cancer, but that's not to say we're not doing a lot of work, and I know our operational and clinical teams are working really hard to get us back on track. In terms of some of the drivers for the cancer position, we are seeing continued high levels of referrals in a number of specialties, but particularly skin and breast. Overall, we've seen over 3,000 referrals again in another month, and this is numbers we have never really seen before as an organisation in terms of referrals on patients on a cancer pathway. The team in the breast service has responded really well operationally with additional super clinics to support the here and now, but I am concerned about the long-term sustainability of their performance just because of the significant rise we continue to see and therefore the knock-on impact it may have for patients. So we're pursuing conversations with our colleagues at Wyre Valley about what a longer-term solution for both of us looks like in terms of sustainable breast service across the ICB. And skin, the lack of a teledermatology service has been a challenge for us. However, I'm pleased to say that we've approved a teledermatology case, and that will be rolling out later this month and into the early part of October. And then just the last thing, particularly on cancer, is oncology is under significant pressure. We had proposed a business case that was put forward to commissioners, however, that were unable to support that at the time. Due to the block nature of that contract, it makes it difficult for us to invest additional money into oncology. However, just to reassure board members and the public, we will continue to make sure that we deliver the services that we need for patients, and our focus is on delivering the capacity we need. Again, just another thank you from me to the oncology team who are going above and beyond in terms of the goodwill and the proactive consultant body who really are going above and beyond to make sure that patients can continue to access treatment. Nothing else from me. Thank you, Chair.
No, very important to have that shout out for all of our frontline teams, but particularly our oncology team this one. Questions and perspectives to Chris? Chris, how is the joint working on fragile services going with Wyre Valley? Is it making the progress at the pace you think it should, or is it a little bit slow?
For me, Chair, I think it's a little bit slower than I would like. It is definitely making progress. We're working well with partners down the road in Hereford, but I think there's more we need to do in a couple of areas that I would like to see do it a little bit faster. I think both organisations have got a role to play in making that happen in terms of being proactive, in terms of driving forward some of the opportunities, not only in fragile services, but also in those services that maybe we could do even better if we build on the success that we've got in some of those services already, like trauma and orthopaedics and opportunities in breast, as I've just referred to.
Okay, great. Thank you, Chris. Keep driving the machine, so to speak, because it's absolutely critical both for our waiting times and for our financial performance. We'll move on then to workforce. Ali, what would you care to pull out in terms of workforce?
Thank you, Chair. Well, with both priorities that I really wanted to highlight today were around sickness reduction and also temporary staffing reduction as well, as they remain our key concerns and areas of focus. With both of these indicators, it's fair to say we've seen progress compared to where we were this time last year. So we know it's moving in the right direction, but in short, it's not fast enough and it's not significant enough in terms of the progress that we need to see. And fundamentally, that translates to we need to make sure our patients are looked after by permanent staff wherever possible rather than agency staff. And we want to improve the health and well-being of our colleagues as well, keeping them at work and preventing that sickness absence in the first place. In order to try and help achieve those aims, there are a few fundamentals that we need to make sure are in place. In the agency world and temporary staffing world, that's a combination of reducing the demand for agency in the first place, so the sickness absence plays into that, but it's also around that grip and control and having scrutiny over those agency rules and the fundamentals of how we will monitor and ensure that we only bring in agency staff or bank staff when we absolutely have to keep services safe. In recognition of the scale of that challenge and the fact that our progress isn't where we need it to be at the moment, we have just been notified that we'll be receiving some increased support from NHS England, and we'll be working together with their temporary staffing programme team to try and accelerate some of that progress that we've started to make, and really look at what will make the difference going forward, particularly as we go into winter, to reduce that reliance on agency staff. Within the sickness absence world, it's slightly more complex in terms of how we control some of that. The protection of health and wellbeing colleagues is, of course, really important. Similarly, we don't want people coming to work when they're not fit to do so either. So it's a delicate balance to strike to make sure that we are supporting colleagues appropriately in the first place to prevent that sickness. And then when people are off sick, supporting them back in the most helpful way, to make sure that they are safe and well at work as well. And there's various factors that impact on that, not only the physical health prevention and promotion and looking after people with appropriate occupational health support, but also when we look at the reasons for sickness around stress and anxiety, we know that people's experience at work is really significant and will really influence whether they're likely to go off sick with stress or not too. So there's a significant amount of work going on around how we instill a culture of kindness and values-led behaviours at work to really make sure that we are supporting people when they're at their most vulnerable, and helping people to do the difficult job that they do and stay well as they do that as well. So that piece of work is also coming together as a bit more of a comprehensive action plan, which we will, when it's ready, bring that back to board to look at in more detail as well. But it pulls together a lot of key elements that are in our people strategy about looking after people's physical and mental health and well-being while they're at work too. I take the rest of the pack as read, but they were the two key bits that I'm probably most worried about and wanted to highlight for the board's attention.
That's great, thank you, Ali. Questions and perspectives to Ali? Clearly an awful lot to do still on the agency side, Ali, and the levels of sickness in the NHS generally are quite frightening, alarming and worrying, all in different proportions. So the work we're doing there, particularly on occupational health and prevention, is very important. So keep up the strong work, please, Ali. So Neil, we're sort of effectively 5 months, but 6 months in. Neil, how are you feeling about the numbers?
Yeah, thank you, Chair. So month 4, we saw an improvement in the month to a 0.1 million favourable position against plan. You'll see on the face of the income and expenditure, you'll see some large variances on income, employee and operating expenses. Much of that is around pass-through in respect of drugs, and we've been asked to bring in an accrual for the pay award. So stripping all of that aside in terms of the underlying challenges, we're still dealing with 2 or 3 thorny issues. I think they're best represented on the second slide in the pack on page 44, where you can see the bridge from the year-to-date plan to the year-to-date actual. So the thorny issues that we're still dealing with, slippage in respect of our CPIP. We've got excess capacity supporting flow. And of course, we've had to take on the additional costs of industrial action and potentially more to come, obviously. Fortunately, they're arguably non-recurrent challenges because we're offsetting those with some non-recurrent benefits at this point in the year. We're able to. So we have got some funds on the balance sheet that we've brought in to offset that. We're fortunate in respect of we've seen a benefit in respect of energy. And we are ahead in respect of our elective income plan. We can't grow our income too much, we've been told, outside of achieving performance standards. But at this point in the year, the performance is still looking solid from a financial perspective. In respect of dealing with those thorny issues, certainly from a CPIP perspective, we did run a sprint, so a dedicated sort of week, 10 days of focus with the divisions wrapped around by the corporate functions around can we move some of those plans from opportunities plans in progress to into plans and delivered. We did see some benefit, as you can see there on the front sheet of the report, but not enough to allay the fears of where we're heading if we're not careful. So you look at slide 46, you'll see the CPIP trajectory in the pack, and the maturity of our schemes isn't keeping pace with where we need it to be. So some much focused effort. We're tracking this weekly with the divisions, and the execs have got a deep dive session with the divisions on Thursday around how we might mitigate that going forward. So much work to do, and as Ali said, there's clearly focus in respect of the agency and from a performance perspective in managing those controls so they don't escape us. From a cash and capital perspective at this point in the year, there's no concerns. I think we'll be on track with those. So happy to take any questions there, Chair. Thank you.
That's great. Thank you, Neil. I think it's just worth saying before I open it up, I believe I'm correct in saying, Stephen, if it wasn't for our financial deficit, we would be on the cusp of being in segment 2 in the National Operating Framework on our other performance measures. So the finances are dragging us down enormously, and as an executive team, us finding solutions to really drive our productivity up and make ourselves more cost effective is absolutely the cornerstone for us to be able to achieve the potential for this organisation. And I'm very ambitious for the potential of this organisation over the next 3 or 4 years. So the next 6 months, it's about us finding solutions to some of the hard problems you identified, Neil, rather than just talking about the hard problems. So questions and perspectives to Neil? Okay, Neil, thank you, and look forward to the fruits of those sessions next week and beyond as we review performance in the finance and performance sessions and the Financial Recovery Board. Colleagues, happy to move on to the safe staffing section of the board. So Justine, as ever, lovely to see you. How are you feeling about midwifery?
Thanks, Chair. So this is the safe staffing report for June. All shifts were safely staffed, but you'll see there was a reduction in the times that we met acuity. That was driven by an increased number of women giving birth in month, and also an increase in acuity, and you'll see there that we move staff around to mitigate that risk. Sickness is down in both groups, I'm pleased to report, but obviously still work to do there. Turnover very low in our midwife group, but as you know, our care assistant group, we have quite a large turnover there that does appear to be reducing, which is good news, particularly in our Band 2 group. Vacancies, very small numbers in our midwifery workforce, 12 whole-time equivalent MCA vacancies, 6 recruited in the pipeline and back out to advert and actually interviewing currently. So we should see that gap close very quickly. The only other thing that I wanted to highlight today was, as you know, the graduate scheme announced by Wes Streetley. We have been approached to see what we can do. We're engaging with that offer as much as we can, but given our financial position and our high levels of fill in our midwifery workforce, there is limitations to what we're able to achieve there at the moment. But everything we can advertise will be advertised, and we'll support where we can. Happy to take any questions.
Thank you, Justine. Any questions or perspectives to Justine on the midwifery staffing levels? Not so much a question about staffing levels, Justine, but how are the team? What's morale like?
I think it's fair to say I've just reported now in June an increased number of births. We had an increased number in July and August. The team are really tired. They've worked incredibly hard, incredibly flexibly. But yeah, morale's a little bit on the lower side than we have had in recent years, because the team is tired, and we're doing all that we can to support them.
Okay, well, can you send them a digital hug from the board and a vote of thanks for everything that they do? Nothing more important, like we said in earlier in my introduction, than bringing life safely into the world. Okay, Tim, we'll move on then to our general nursing staffing levels. And Hayley, are you going to take this?
I am, yeah. I've also got Sue on the call as well for any technical questions that you may have. So just a few things really I want to raise is our fill rate is in line with guidance for both our healthcare support workers and our RM workforce. Also, our care hours per patient per day is also in line with national variance, which is very positive. We triangulate any incidents to our staffing levels and nothing has come apparent that is of concern. We continue working on our CPIP in terms of the reduction of agency, and that is going in the right direction. The one area where we are challenged, and it's going back to what Neil and Chris were talking about, is our escalation areas. So our escalation areas are our areas of concern where we are requiring additional agency and bank staff. So that's it really in a nutshell. I'm very happy to take any questions. Thank you,
Hayley. So thank you for joining us today. Anything you'd like to add, given that you've been here more than a week?
Thank you, Chair. Just say about the graduate guarantee scheme, as Justine's just touched on for general nursing. So we're able to offer all our graduates placements from this cohort coming out September, October. And currently we're just mapping against the cohort that comes out next February. At the minute, we think we're able to guarantee 50% of those, but looking at attrition rates, we're actually hopeful that we'll be able to offer most of our graduates next February as well. So just working through that. The other piece of work we're going to embark on, we've been accepted onto cohort 3 for the enhanced therapeutic observations of care national work, which looks at our special patients, because that's a lot of our cost as well around our agency. So engaging with that piece of work will just be able to, for us to work more around reducing our bank and agency around that cohort of patients. So really positive that we've been accepted onto that cohort of work.
Thank you. No, thank you, Susan. Any questions or perspectives to Hayley? Great to have you on board, Hayley, and it's always good to have a fresh pair of eyes on any issue. So look forward to your contribution going forwards. But thank you for joining us as, on an interim basis. We'll move on then to the perinatal safety report, which will obviously take as read, Justine, but anything you'd particularly like to pull out?
I think the main things that I'd like to pull out today are you'll see an increase in complaints there, which was obviously somewhat of concern in the quarter. We've had a look and there don't appear to be any significant themes. We have, as you know, been working on delay in medication and delay in induction for some time now and are bringing that down, but obviously there's always more work that we can do in those areas. Medical workforce middle grade challenges still continue, but there are mitigations in place, and I believe from September we've had better middle grade fill from the deanery, so that's been welcomed. You'll see in the Safety Champions walkabout there was some concerns raised around triage, the busyness in triage. And unfortunately, which is very unusual, our triage telephone midwife had been escalated out and into another area. So the team were reminded that that post is ring fenced. And our CNST position, you'll see there, although it's declaring that we are confident in 9 out of 10 areas at the moment, we do have some challenges in our medical workforce prompt percentage at the moment, but we're pretty confident that we'll get that across the line. It's similar to last year, same issues driving that, and we managed to do it last year, so not too worried. And as you know, our MMVP colleagues, we've lost 2 out of the 3 of the team, so their engagement and co-production has dropped off a little bit. We will continue to do what we can. There is a paper going to the LM&S board next week, and I will bring the feedback from that. But I think there'll be good actions in place that will mitigate against that safety action, and we'll be able to declare compliance because there'll be a an action plan in place. And other than that, I'll just take any questions, Chair. Thank you.
Thank you, Justine. We'll obviously come on to the CNST sign off in just a second, but any questions or perspectives to Justine? Sue, as our net safety champion for maternity, Justine obviously mentioned the issue on the last walk around. Anything you'd like to add in terms of perinatal safety?
No, what I can tell you, Chair, is that we had a very immediate response from Justine and her team, and immediate mitigations were put in on the day we raised them. And there have been subsequent changes there too, which sort of highlights the strength of this champion process across our foundation, in that we can ask questions and we get answers, and hopefully that provides the board the assurance that that process should do.
Yeah, no, absolutely. And openness is absolutely key aspect of this.
Yeah.
Justine, there's just one issue I want to raise, and apologies for this being potentially a bit of a curveball with you, but you'll be aware that on occasion tragedies do occur with the birth of babies, and particularly the increased risk for having a baby at home. And I'd just like you to take away with whether we're clear enough with parents on occasion with our advice about the increased risk of having a baby at home in different circumstances, whether in our desire to try and give mothers choice, that we're making sure we're fulfilling our obligations on providing straightforward advice about risk. Can I ask you to take that away? Sue, is there anything you want to add?
It was just to say, actually, a little while ago, we had a tragedy rising in that sort of situation, and on one of our walkarounds, we spoke to the midwives that provide that service, and we were both myself and the previous CNO were very impressed with the detail and the logging and the record of the information that was passed on. And I'd just like to have a little shout out here for midwives. It's largely midwives, but occasionally obstetricians, being in an invidious position that no other healthcare worker is in that they have to provide care in an environment that they have advised is not safe. And we do not ask any other healthcare professional to do that. So I think they're in a very difficult position, and they deliver it in great spirit and with great courage, actually.
I absolutely agree. So it's just I want to ensure for our midwives that the parents have got total clarity over their advice from the midwifery professionals. Justine?
Yeah, just to give assurance, Chair, we have a very robust policy. There's always room for improvement, and we are doing some improvement work around in that space at the moment. We've just received the principles for the from the NMC around women who birth outside of guidance and those who free birth. So we're just matching our, sort of doing a bit of a gap analysis on what does our what advice are we giving and what do the principles recommend. In addition to that, I think we've talked here, the MMVP and the team have co-produced something called Brains. That will be rolled out soon, and that supports informed decision making. There's also clear senior leadership on for any woman who is requesting care outside of guidance, and we provide very clear discussions, but also follow up in letters and have a very robust correspondence that we send to families that make it really clear about the risks and the benefits of their choice to birth at home. So I feel there's always opportunity to improve, but I feel that we've got quite a strong process in this space at the moment, but can be enhanced.
Thanks, Justine. We'll move on then with colleagues' forbearance, just for the sign off of the because we need to, I think, sign off on the CNST MIS. Is that correct, Justine?
Yeah, so this CNST Q1 report here is just for recording. Due diligence in terms of the evidence was discussed at Quality Governance Committee. As I said, we're currently confident in 8 out of 10, and those 2 areas of focus that I previously discussed, we will report back at the end of Q2 where we are finally, but I'm very confident that we'll deliver the 10 again this year. Thank you.
Super. Thank you, Justine. Julie Moore, as Chair of our Quality Assurance Committee, anything you want to add?
No, thank you. I think Justine's covered that quite a lot. There's been a lot going on in midwifery, but the notes are often a couple of months behind, but there may well be some more to come about that in a little bit, and I see by Justine's knowing smile that is indeed the case.
Okay, thank you, Julie. Okay, so if you're not happy to approve this submission, please raise a digital hand. Thank you. So we'll then move on to the absolutely key issue as we approach our winter plan. Chris, over to you.
Thanks very much, Chair. I'll take the mini papers as read. So yeah, it's a cover paper, the board assurance statements, and then the high-level winter plans included. I'll just pull out a few bits I wanted to raise the board's awareness. So it's been a bit of an earlier start than usual to winter planning nationally and regionally, which is, I think, it's been a good thing for us and also with our system partners. What you've got in the papers today is sort of the high-level plan pulled together from input across the organisation and all professional groups to the various other forums that we have. And also linking into the work that the system has been doing around the systems winter plan. So very much this is a part of the systems winter plan. From an operational point of view particularly, there isn't anything new in here. These are schemes that we are progressing as part of our UEC recovery and UEC transformation programmes. As the Chief Operating Officer, I'm the nominated Winter Director for the organisation, and we will be increasing executive presence into the emergency departments over the winter period, so that we can make sure that we're supporting our teams at the front line. There's lots of detail in there, and I'm happy to take any questions in due course. But just to note that this plan will continue to evolve through September and into early October. There's a number of stress tests, as they're being called, or assurance exercises taking place. The first of those was an assurance visit to the system on the 2nd of September, and which took place at the ICB with all system partners. And there's a regional tabletop stress test taking place on the 17th of September, which will inform any changes to the plan. There are some risks around winter, as I'm sure you can all appreciate. The big one for me is around the non-delivery of either any of our internal, and more importantly, some of the system schemes. I am particularly concerned about the system modelling that we'll see a 2% reduction in emergency department tendencies, because I don't think we've ever seen that in the past, and that does give me cause to stay awake at night from a winter planning point of view in terms of how deliverable and how achievable that will be in terms of the impact it could have on the organisation if it's not achieved. And hospital at home is our big opportunity as a system, and as I talked about earlier, the fact that we've got the support from the ICB in terms of the funding and the rollout of that will be led through the UEC transformation programme over the coming weeks and months. But we have really got to look after our staff is the other bit I just would like to draw attention to, really. There's lots of modelling, there's lots of numbers in all of this, but it's the people that will make the difference. And not only our colleagues in the organisation and in the system, but also the public in terms of, and patients in terms of their behaviours, in terms of where we choose to access services over the winter period in particular. So then next sort of steps for this are the regional stress test on the 17th of October. There's also an ICB clinical risk workshop happening on the 17th of September with clinicians from all partners getting together and helping to work out how as a system we're going to share the risk, balancing the needs, the responsibilities of individual clinicians to manage the responsibility they have around risk to individual patients, as well as our collective responsibility to manage the overall risk for all our patients. We will be holding a clinical engagement session with clinical leads in terms of further development about additional actions as a result of that clinical risk workshop on the 17th of September. And so after that, we will review the quality impact assessment based on the latest version of the plan by the end of the month. And then submitting the board assurance statement subject to approval today to NHS England at the end of the month, with the caveat that the plan may change between now and then based on but only based on feedback from the stress tests and their clinical risk workshops. Happy to take any questions because I'm conscious there is a lot in that pack, but I'm also conscious of time.
No, absolutely, Chris. But as you say, it's a key issue, and I'd just like to emphasise to members of the public, as winter approaches, as Chris sort of indicated in passing, it is incredibly important that you only use the emergency department at the acute hospitals in an absolute emergency. If you can go to a pharmacy, please do so. If you can go to your GP, please do so. If you can use NHS 111, please do so. The A&Es are going to be incredibly busy, and we need to protect them for those who are in a really acute emergency situation. I'll allow Stephen to come in first, and then I'll go to Tony. Stephen?
Yeah, just wanted to pull up a couple of bits and also a really important message. So one of the bits that there's two things we're trying to do as well this winter that I'm not sure we've done as well last. One is talking around how many empty beds do we need around Christmas Eve as a focal point for what's the following weeks look like, knowing what we know. So that's something that Chris is leading, and I think we're having that conversation in the system. So how do we all gear up for that? The other bit is we go around this, but there is some really important learning from Australia. So if you look at Australia's example now, what it is telling us is that it's likely the flu season will come early. It could be intense, and it's particularly the vulnerable, so older people and young people. So again, for our winter plan, one of the things that we will be looking at is those paediatric rates as a first sign that we're starting on it. But a big piece of learning out of Australia is if you're eligible for a vaccine, get one, because that can absolutely flatten the curve. And then that means that as a whole population, we can get access to the healthcare that we need. So just to build on your point, Russell, about how we need it, that vaccination looks disproportionately important as well.
Okay, no, super, thank you. I absolutely agree with that. Tony?
Thanks, Chair. Chris, you referenced the system assumption that there'll be a 2% reduction in demand at the front door and a concern over this. What's that predicated on, please, in terms of system response?
In terms of, so that's predicated on alternatives to the emergency department in terms of the access to the same day access hubs, which is a supporting primary care, additional primary care capacity, also work that they are doing, that we're doing as a system around working with care homes and to prevent patients being conveyed to hospital when there's a respect formal means they shouldn't be coming to hospital, better their care needs are met in their place of residence are the main sort of drivers, and then work through single point of access, things like urgent community response teams and things that will stop people coming to the front door.
I think it's a very well made point though, Tony, that we need to work with partners in the community to minimise traffic into the acutes. Simon?
Thanks, Russell. I was going to raise that point as well, but just also to mention that on the Transformation Tuesday session that we had earlier today, chaired by Rena, there were some encouraging updates on the single point of access and the local 111 referral system. So I think we're making some progress there. Chris, my question really was going to be about Urgent Treatment Centre, given that this was mentioned to us last November when NHSE came and inspected us, or our winter plan. And you did sort of say that these are things that have been around for a while. There's nothing new under the sun. So I just wonder, you know, how we're addressing that space if we're not actually going to physically have one. What does that look like in terms of something that might fill that gap?
Great question, Simon. So I think we're not going to fully fill that gap. So I'm not going to sit here and say as a system, I think we've got a plan that fully fills the gap that an urgent treatment centre could fill. Clearly, moving the GP from the emergency department to the old ED to sit alongside our same-day emergency care services does provide some elements of how we can support that and other options to work differently together for those teams working down there. We have talked about, once we've seen how that goes, whether or not there'd be scope to move more services such as our miners stream into that space on the Worcestershire site, which would effectively give us an urgent treatment centre on the Worcester site. But given space constraints at the moment, we want to see how the initial move goes. Interestingly, there is limited mention of the role minor injury units can play in the system-wide winter plan, and that was one of the things that was raised as part of that initial visit from NHS England to the ICB and to system partners earlier this month. So I think we'll see more in that space over the coming days and weeks.
Okay, thank you. Any other questions or perspectives to Chris on the winter plan? I can't see any digital hands raised. Finally, Neil, then we'll move on.
Yeah, just to highlight for the board, recognising the risks that Chris has outlined there, and out with the funds that have been put forward from the ICB in respect of hospital and the home, we don't have a fund to support winter as an organisation, and clearly we're still struggling to get out of that capacity that we had in last winter. So we do absolutely need to be focused on this and not incurring that additional money without full visibility and sight on it if that should be the need.
Yeah, no, absolutely. And so I just encourage my executive team to sort that out. It's one of the advantages of being a non-executive director. Okay. It's a unitary board, but we're not full-time employees, but we're there to help. Colleagues, happy to move on? So move on then to our board committee reports. The first is the Quality Governance Committee and the July minutes. Julie, is there anything you'd particularly like to emphasise?
I don't think so, thank you. Things that we did discuss have been covered in other parts of the board, so I think that the rest of the minutes cover it all very well. Thank you.
Thank you, Julie. Thank you for chairing that subcommittee. Any questions or perspectives on those minutes? Move on then to the Audit and Assurance Committee. Colin, anything you'd like to pull out?
Thank you, Chair. There are no red alerts, but there are two advisory items I'd like to just say a few words about. First one is that we had an further external review of the construction of the UEC, and the particular brief was to look at value for money, and the question was, did we achieve value for money? And they broke it down into the conventional elements of value for money: economy, efficiency and effectiveness. Economy, we didn't get a tick in the box. They felt that because of the cost overruns, the capital being so much more than we budgeted, it couldn't be described as value for money from an economy viewpoint. But from efficiency and effectiveness, they were satisfied that we had achieved value for money. Although with regard to effectiveness, there were certain learnings which the committee were assured that the executive have taken on board. So that sort of concludes that chapter. We don't plan any further work specifically on the issue, but we will continue to keep an eye on the lessons learnt from the overall project. And the second one relates to the external auditor's comments on value for money, and in particular on our processes for CPIPs. They made some comments about whether our CPIP process was off the ground quickly enough, which was, to be fair, not agreed with. We took the view that we followed the pattern we did last year, which was successful. But nevertheless, it's an important comment, and we plan to review the whole CPIPs process in more detail at the next meeting. That's all. Thank you.
Super. Thank you, Colin. Any questions or perspectives to Colin? Okay, we'll move on, and I will take as read in her absence the People and Culture Committee minutes. Any questions on those? Okay, and then the PFI Exit Committee. Thanks, Tony, for chairing this. I know it's still early days, but important work. Anything you'd like to emphasise?
Thanks, Chair. Well, as you say, just 2 meetings in, so we're just finding our feet, but I think we've now got a good grip on what we need to do. You'll see from the short summary report 3 main areas of focus in this quarter: getting a resource plan in place so that we can respond to this, and that's looking very much at working jointly with Wye Valley, who are in the same process but 2 years in front with some material differences. Secondly, really critically, we hope in the next quarter we'll be able to recommend to the board the signing off of the joint compliance and conditions survey, which is absolutely critical to understanding where we go next. But high level of confidence, I think I'm hearing from estates and facilities that we're close to getting that on the ground, which is excellent news. And finally, we've identified a significant potential area of risk, which is to do with the managed equipment service contracts and Siemens element of that within the PFI arrangements. And so piece of work being led by Chris, which is going to look at the whole managed equipment service arrangement. So a lot to do, but I think we're now starting to get a grip on it, and hopefully as we progress forward, you'll start to see some actions being delivered. Thanks.
Super, thank you, Tony. Any questions to Tony? So our next meeting's on the 14th of October, but we talked about some questions from members of the public. Gwynnie, do we have any other questions from members of the public as we've covered the car parking one?
No, that was just the car parking.
Okay, great, thank you. So any other business, colleagues? Please raise a digital hand. Okay, just for members of staff who may be watching, thank you very much for your hard work. I hope you had a nice holiday if you've had a holiday, but as we said under Chris's presentation, winter is coming and we're very conscious of the amount of hard work which is heading all of our way. That's in spite of the hard work that goes on day in, day out. Rena, lovely to see you join us at the public board meeting. Thank you for all the work you do in the Embrace Network and in your day job as well. We look forward to seeing colleagues, like I said, on the 14th of October. Can I suggest to board colleagues we have a 10-minute break and then we dive in early into the confidential board. So see you in 10 minutes. Thank you. Bye-bye.